welcome you all here, dear faculty and audience, for our online Zoom webinar on the topic of palliative care and pain management, early integration and perspective from medical oncologist point of view. So this is our monthly meeting held by Society for Study of Pain Pune every month last Monday. This we have been conducting since COVID times uninterrupted. Okay. So I would like to welcome Dr. Joy Shankar Jana, President, to carry forward.
Thank you, Varsha, for starting this meeting. I welcome all our esteemed faculty members and all our honorable members and delegates who have joined online for this excellent clinical and academic meet on palliative care and pain medicine. And we have got Dr. Sushma Bhatnagar, ma'am, who is the esteemed faculty in teaching pain, palliative care and pain medicine. And we have got Dr. Amit Bhatt, who will give the medical oncologist part view. And it will be definitely an academic feast to hear the stalwarts in palliative care in our platform of Society of Study of Pain in Pune City branch. And our today's moderator is our nonetheless Dr. Manohar. He's a pain consultant and anesthesiologist at Poona Hospital and Jalaram Hospital. Multiple publications, very dynamic, and multiple presentations in various conferences at this national level and state level. And our today's local member who is going to be along with our esteemed faculty is Dr. Nivedita. She works in Cipla Hospital, and she's also excellent for giving palliative care. So with this few words as a president, I hand over to Dr. Manas as a moderator to carry forward the today's proceeding. Dr. Manas, please unmute yourself.
Thank you, Joy sir, for the kind introduction. I welcome all of you. So today's topic for the webinar is pain and palliative care. So palliative care is a relatively new concept, new term, but as a concept, it is not new. Care of the dying has been a constant feature of our human society. Palliative care historically has been considered as a service only for cancer patients. But as the time has progressed, we have realized that it is needed for patients with other chronic and incurable illnesses as well. Well, palliative care is an approach to say is that improves the quality of life of patients with life-threatening illnesses. It also deals with the problems of the family members, and it also helps them in taking right decisions at the right time. Today, we have eminent speakers with us to discuss this topic, Dr. Sushma Bhatnagar, Dr. Nivedita, and Dr. Amit Bhatt. So with this, I introduce our first speaker, Dr. Sushma Bhatnagar. Share my screen. All of us here know Dr. Sushma Bhatnagar, madam. She has done her MD in anesthesia and MSc in palliative care medicine from Cardiff University. She is a professor and head of department of Onco-Anaesthesia, palliative care and pain at IRCH AIIMS. And she's also the head of National Cancer Institute AIIMS, Jajjar. She is the editor of Indian Journal of Palliative Care. She's been on the IISP Council board for 6 years. She's been a part of board of directors for IAHST, that is the International Association of Hospice and Palliative Care, for 3 years. She has been a recipient of numerous awards and accolades. She's organized numerous national and international conferences, and she has several academic and non-academic publications. I welcome you, madam, and hand over to you.
Thank you, Manas. Thank you very much. Thank you, Dr. Joy, Dr. Varsha, and Nivedita, and everyone, those who have joined today. I'm really happy whenever can you allow me to share, because this will stop other sharing? Can you allow me to share?
I'll
You have
stop.
to
Yeah.
stop sharing.
Yeah.
Yeah.
So, okay. So when I got a call that I have to speak on integration of palliative care, so I was whenever somebody asked me for this, I always remain ready, because I really want that integration of palliative care should happen in true sense all over the country, in all the branches where the patients are suffering. So we all know by this time that most of the people, they must have heard about the name palliative care, because we are fortunate that at least we are hearing this word during our residency program. We never used to hear this word at all. So now we are hearing, and everybody has started talking. Everybody has started talking about this word, and they are trying to integrate palliative care of concept in their day-to-day practice. So what I will talk about integration of palliative care, how it should do, what are the steps. Always there is a dilemma that when to integrate and when not to integrate. So accordingly we will discuss everything. So this will be my flow presentation, that what is the philosophy of palliative care, how does palliative care fits into acute care setting, what is the magnitude of problem, how to recognize transition, why is palliative care of why delivery of palliative care is different, and then benefit of integration of palliative care models and challenges. What are the challenges? So this is a philosophy. This is not a new philosophy, as Manas has just said, that we were knowing about palliative care. India was the country where we take care of our elderly, all sick patient, even in the neighborhood. So we have inborn our nature that we are a good human being, and we take care of our parents, our elderly, and the neighborhood. That's why the King Ashoka, in almost in the 200 BC, he has made uh, the shelter home for the elderly and sick patients in the Gangetic Plain. So this was, since that time, this is there, but unfortunately in the current era, in the learning of too many technological advancement, we have forgotten this part of medical science, and what we have concentrated, and this was again not our fault, we have concentrated truly on diagnosis and treatment. But what is happening after the treatment, and if treatment is not possible, what should we do? We have forgotten that part, and we have also forgotten the philosophy and the oath which we have taken, that when disease becomes violent, we should not treat the disease, but try to ease the symptoms. And this is the philosophy of palliative care. So any disease, that can be cancer, that can be end-stage heart disease, end-stage lung disease, end-stage cardiac disease, end-stage kidney disease. If disease is becoming violent, a time will come when we should stop treating that patient, and we should try to manage the symptoms without curing the underlying disease, without trying to cure underlying disease. But whenever we talk about palliative care, this always is a concept that palliative care should be given at the end of life, which is not the true concept. This is the right concept right now, and this we should learn. This is a very famous and very frequently you must have seen this photograph. But if we will understand this slide, I think we have understood integration of palliative care. So what exactly this slide says, that we have to start palliative care right from the beginning. This means those who are listening this lecture, they should have a basic concept of taking care as a patient, as a holistic care right from the beginning. And as the disease will progress, initially it will be disease directed treatment mainly, and as the disease will progress, then there will be minimum disease directed treatment, or but then further when disease will progress and there will be no disease directed treatment, that time palliative care can take the lead. So right from the beginning we should have a habit of giving holistic care to the patient, those who are suffering with chronic illness. So for example, a patient of carcinoma breast, if she has come in the beginning, she is very anxious, she is very confused what exactly will happen, whether they will remove my breast, what will happen to after chemotherapy, who will look after my children, who will take care of my husband. So there are so many things, and it is important that just for giving by extra 5 minutes, we can clear all these doubts, give realistic hope and honest information right from the beginning. So this is what right from the beginning, every physician, whether he is cardiologist, endocrinologist, they should have a habit of doing this. And as the disease will progress, specialist palliative care should take the lead, and patient should be given a good end of life care and as well as the care after death. So honest information and realistic hope throughout the journey of any disease is most important in continuum of care. Now, how does palliative care concept fits into acute care setting? So I just will tell you that in acute care setting, what is our role as an anesthesiologist, as an oncologist? What we do, we maintain the vital function, we reduce the mortality, and we prevent the morbidity. But what exactly our aim should be? That goals during transition. When we try to start palliative care, we don't know what exactly the transition is. When we should start giving palliative care, always there is a question and there is a confusion and there is a dilemma that when we should try to incorporate palliative care, specialist palliative care, we should affirm life and regards dying as a normal process. We should promote quality of life, definitely, and we should giving address to quality of life without interfering quantity of life. We should try to treat a person rather than the disease, and we should support the family when patient is suffering with, because when patient is suffering with chronic advanced illness, it's not only the patient who is suffering, it's the whole family is suffering. So this is just a very good paper which everybody should read, that how to decide that need of palliative care in acute care setting. This is a gold standard framework which will give you the prognostic indicator criteria in various circumstances and various stages or various disease trajectory. So what are the patients? Those who should be definitely, there should be integration of palliative care. This is the percentage of patient. Imagine almost 20% of heart disease, end stage heart disease patient, they need that there should be a dedicated palliative care facility in the hospital. Similarly, cancer patients, just it's not that number. So you can see that end stage heart disease percentage is equal to cancer patients. Similarly, COPD, dementia, and all these patients need palliative care or integration of palliative care. So this is just an example which give you the last month audit of our patient which we have seen, and you can see that the distribution of patient was from all the departments like heart, cardiology, endocrinology, pulmonary medicine, and these are the consultation which we have seen, and you can see that almost in every month in all these patients, they either need symptom management and or end of life care. Similarly, in March, April, when disease management group in cancer patient, and you can see that if 800 and patient visit, total patients have visited, almost 240 patients, they needed palliative care right from the beginning. This means they presented in advanced stage, and there was a need of integration of palliative care right from the beginning. Now, palliative care in intensive care unit, there must be a lot of intensivists in the year. So there is always a question: why, where, what, who, and when, and how. So this is the summary of this paper: is that almost 14 to 20% of patients in ICU meet the typical trigger of palliative care consultation, but hardly any ICU is doing palliative care consultation. Almost all the patients in ICU we are treating to full. Till the time patient they will not say themselves that now I really don't want to further treatment, or patient will stop breathing, patient will his or her heart will stop, then only we will stop. So we should have a habit of integrating palliative care in even in ICU, and this is just a in emergency department consultation of last 6 months, that if we have seen 225 patients, almost 160 patients needed palliative care right from the beginning. This is our own data. And imagine in intensive care, in emergency department, we have no concept of palliative care at all. And every patient who is coming gasping or breathless, if he is breathless, we are intubating, we are resuscitating every patient. But almost 71.11% patients required palliative care, right, consultation right from the. So that's why our resident is always posted in emergency department, and now we have integrated intensively palliative care in emergency, cardiology, pulmonology, and endocrinology, and various other departments. This is in oncology. We all know that oncology patient at the end stage almost they need palliative care definitely. So, what are the barriers? Why we are unable to decide that what is the transition point? So, exactly first we should understand what exactly the transition point is. So, transition point is just a definition in which we should know that a transition to palliative care is defined as shift from curative treatment, a focus on cure or chronic disease management, to palliative care with the aim to maximize quality of life. So when our focus shifted from cure to care, that is the transition point. What are the significant barriers to implementing transition to palliative care is because we don't know how to recognize transition point. We don't know. We keep treating. And lack of effective communication. We don't want to talk to the patients, and we don't want to talk to the patient in detail. We don't want to talk to the colleagues in detail. So everybody will keep referring to each other, and finally patient dies. It's like if patient is not having the urine output is nil, we will send consultation to nephro. If blood pressure is low, we will send consultation to cardiologist. But we don't talk to each other, and so that we can make a final decision for the patient. So a holistic approach is lacking in almost all the ICUs. And how? What are the trigger point? Question is, if you start thinking that I will not be surprised if this person will have a life expectancy of months, weeks, or days. That time, if you start thinking that this person may not survive for or it's a matter of few weeks or few days, then we should start thinking intensively integrating palliative care. And general indicators of decline are deteriorating. Patient is deteriorating. Clinically, we know that patient is deteriorating, but we keep treating that patient. Increased need of choice of intensive care and further active care. If patient is dependent, almost all the time he is on bed, he is requiring oxygen almost 24 hours. He is not eating. He is not liking. He is almost on the bed for almost 24 hours, and he is requiring all sorts of supports, even to go to the toilet. I think we should start thinking that this patient there is a need to integrate palliative care intensively. So we should identify, we should assess, and we should plan right from the beginning, right in right time, that when is the primary care physician, even they can take care, but when specialist palliative care is required in the trajectory of chronic diseases. So these are the various transition points which I have already narrated. We should assess the patient, establish person's capacity. We should try to find out who's surrogate decision maker or patient can make the decision. We should document everything. We should review. And finally, we should take the goals, and everything will depend on your communication, proper communication. So communicate. So why delivery of palliative care is different in acute care setting? Most of the time, professional culture is saving life, vital sign monitoring. So all these are very important barriers. Time course is always no time to talk to the patient. Uncertainty and environment which is not teaching communication in the right time. So if we will integrate palliative care, it's not only the patient who will be benefited, it will be the staff and organization. Everyone will get benefit. So these are the benefits for the organization. We will have reduced pressure on beds, reduced costs, fewer complaints, and fewer hospital deaths. So if we will integrate palliative care, there will be a lot of communication. There will be a habit of giving realistic hope and honest information. So there will be less complaints. What are the benefits to staff? Open more opportunity for formal and informal education. We feel better, reduce anxiety, and feel more confident. So, if we will integrate palliative care, a lot of family meetings will happen. There will be a better understanding of diagnosis and prognosis amongst patient and family members. There will be a opportunity to give informed choices to the patients. Means patient will be able to make choice about the treatment, and there will be better patient physician relationship. So these are the models of palliative care. It's an integrative model. Means many hospital we can integrate palliative care in continuum of care. Means palliative care physician should remain on the rounds, and they will be taking care of the patient whenever it is required. There are advantage and disadvantage of this. Similarly, consultative model, if you don't have palliative care physician for round the clock, then you can send consultation whenever required. So it is again, there are advantage and disadvantage of this model. Most of the time, mixed model works, that primary physician and treating physician straightforward calls the patient whenever there is a palliative care need, and this is most accepted model everywhere. So these are the challenges. At physician level, they don't understand about transition, and they consider palliative care as end of life care. No formal training of communication and complexity of various diseases. This is true that in cancer it will be easy to integrate palliative care, but in non-malignant disease we consider that they will not die at all. So it will be a very, very difficult task if we want to integrate palliative care in non-malignant diseases. Patient level is also, it's not only the fault of ours, patients also do not leave hopeful of technological advancement. They always remain in denial. There is conflict of interest and poor understanding of healthcare system. So this is old data, 2015 quality of death index. India is very poorly performing as far as quality of death is considered. In 2021, again, the index has come. We have not improved much. We have just, that time we were on 69th position and now we are on 60th position. So we are not doing well at all. So this means India is not a place where we can get dignified. And so why the best countries where the end was good, they were having a strong and effective implementation of palliative care program in continuum of care. So the countries where there is a automatically, even an MBBS student learns a concept of palliative care. Every doctors and those who are getting trained, they are learning and they are integrating palliative care program right from the beginning, and that's why they are having good quality end of life, good dignified end, and they are on the top. So quality of death on these countries are really good. So crisis can be managed by simple learning, safe use of opioids. These are the children. We know that they are not going to survive for a long time if it is incurable disease, but we can relieve their pain, we can relieve their suffering, we can relieve their crying, and we can give a lot of relief to their parents. This is AIIMS and pain policy, where not a single patient who is registered in AIIMS, whether OPD or IPD, they always remain pain free. This is pain policy of AIIMS. This is a nursing chart where we teach and educate that nurses that this is important to treat pain as a fifth vital sign. So they are monitoring it, and whenever there is a pain, we give a lot of emphasis to nurses, because nurses are the backbone of system, of any of the system, whether it is ICU or palliative care. So we give a lot of training to nurses. This is end of life care policy of AIIMS, where all the patients, those who are registered in AIIMS, should get dignified end. These are the steps. We recognize dying as a normal process. If patient is dying because of any chronic illness, we give honest, accurate, and early disclosure of prognosis to the family. We sit down with the family, with the primary care physician, and we have a proper communication amongst physician, supporting staff and patient family. When there are consensus amongst all the caregivers, since when everybody is on the same page, we give transparent and accountability through documentation. So transparency and documentation is very, very good. So whatever we have discussed in the family meetings, we document it, and we initiate end of life care policy, where purpose is neither to hasten death or nor postpone death, neither to hasten death by giving some medication and we are not going to postpone death by putting patient in ICU or on vasopressor. So summary, integration of palliative care in continuum of care is a need and we must learn. And I'm really happy that today we are discussing, and those who really wants to get training, Indian Association of Palliative Care is giving various types of training to the people, those who wants to learn palliative care. Extension of services need to go beyond cancer, because it is not only cancer patient who needs palliative care. We need to increase awareness amongst patients and physicians, both, because both are the party. And it is not only the physician they are having lack of knowledge, but patients should also understand when a disease has progressed and the disease has reached to a certain stage where treatment is not possible, we should stop treating and start caring. We should distinguish palliative care is not only end of life care. A good team is required and multidisciplinary team approach will work. So goals should remain: relieve suffering, give comfort, maintain human dignity, respect patient and wishes, improve quality of life, and emotional support. So this is my last slide, that we should create a system where we want to die. Otherwise, all of us will die in ICU with all tubes and ventilators. If we will not create a system in our hospital, if we will create a system and tomorrow, unfortunately, we are suffering with any chronic diseases, then our residents and doctors, they know that there is a system and we should provide comfort care and allow ourselves to die at home without any suffering. So reality is that everybody wants to die at home, but we all are dying most of the time. Rich are dying in ICU because they can afford ICU. Middle person is in crisis. They just run around to sell off their land and just to get an ICU bed. And poor person, if they don't get ICU bed, they remain always in guilt that my patient or my loved one had died because we couldn't get ICU bed. So everyone is suffering in this world, in this country. So it is the right time that we should start thinking about it, that by giving honest information, realistic hope, some good symptom control, patient can die peacefully at home. Thank you very much. And we should not forget that we have to teach humanity to all our doctors, because humanity is a wonder drug. There is no overdose. There is no underdose. Thank you very much.
Thank you, madam. That was an excellent presentation. A wonderful insight and to how to go about integrating palliative care in specialties. As I can see, it is a big challenge because of a lot of barriers, like you mentioned. Firstly, is to identify the transition point, and secondly, the lack of communication between colleagues and also between the caregivers and the relatives. So I think we'll take questions at the end. So we'll move on to our next speaker.
That was very informative lecture, Sushma. Nice to see you at Pune SSPP.
Thank you. Thank you very much. Thank you. Thank you.
We need to have you in person here so that will give a great boost.
Whenever you will say, not a problem. It is not a problem. Don't worry. I'll come, no problem.
So our next speaker is Dr. Nivedita Page. She is a consultant pain management consultant at Cipla Palliative Care and Training Center, Pune. She's a director of PNX Pain Management Clinic, and she's also a consultant pain management consultant at various hospitals around Pune, Jupiter Hospital, Reach Hospital, and she has several academic and non-academic publications. With a keen interest in cancer pain, she has developed and published a protocol for cancer wound dressing analgesia, which is now widely used in palliative care community. I welcome you, Dr. Nivedita, and hand over the session to you.
Thank you, Dr. Manas, for the kind introduction. I will share my screen. Is my screen visible? Yes, it's visible, Nivedita.
Yes.
You can go on. Okay. So the topic that I have for today is opioids and palliative pain management. Since most of the audience is
palliative pain management physicians, all of us are well versed with using opioids and are regularly managing cancer pain. So today I have structured my talk in such a way that I've included a lot of practical aspects which we come across in day-to-day cancer pain practice and which are usually not talked about much. So a little bit about the history. Opioid is the term used broadly to describe all compounds which act on opioid receptors. Narcotics, initially it was used for sleep medicines, then to describe opioids. And now as we all are hearing about the Narcotic Control Board with the Bollywood scandals that are happening, it's a legal term for drugs which are abused. The important part in this is opium poppy was cultivated as early as 3400 BC. And even ancient Egyptian papyrus records have reported use of opium for pain relief. So pain management or pain medicine is as ancient as the history of medicine itself. Coming to opioid receptors, we are aware about the mu, kappa, delta, sigma, and there is a new receptor which is coming up. But the mu opioid receptor for all practical purposes, mu and kappa are the important ones for our clinical practice. So mu is responsible for all the clinical effects and adverse effects that we see, like analgesia, euphoria, respiratory depression, constipation, nausea, vomiting, urinary retention. Kappa also to some extent analgesia, sedation, respiratory depression. But I have highlighted the words dysphoria and euphoria. So as is obvious from this slide that mu receptors are the ones which are responsible for the high that patients get after opioids. And that is why drugs of abuse and even medicinal opioids that are abused, they are mainly mu opioid receptors. Kappa, delta, and sigma gives an unpleasant feeling or a dysphoria. So looking at the commonly used drugs, morphine is a strong mu agonist with doubtful action on kappa and delta. Even if it has any action, it will be agonistic action. Fentanyl being a synthetic opioid, it has a strong affinity as well as agonistic activity at the mu opioid receptors. Buprenorphine, which we again commonly use, the patches, it is a partial agonist at the mu opioid receptor and an antagonist at the kappa and delta receptors. Naloxone, naltrexone, these are antagonists. So opioids can be classified based on their action. Most opioids which we use clinically are agonists, like morphine, fentanyl derivatives, as well as codeine. And the differences in activity and efficacy is mainly due to differences in the stimulation of the receptors, and also genetic differences are responsible for differences in sensitivity. Buprenorphine is another partial agonist which we use commonly. So what do we mean by partial agonist? It binds with the receptor with high affinity, but efficacy is low, and that's why it yields a partial effect. Agonist, antagonist, we are using pentazocine in anesthesia practice, mainly not used much for chronic pain. And naloxone, naltrexone, these are antagonists, mainly used if there is any opioid poisoning. So we come to the metabolism. So all of us have read opioid metabolism at some point of time or the other. So I have just put together important pointers of metabolism, which are important for our clinical practice. So hepatic metabolism, as we all know, is divided into phase 1 and phase 2. So just to refresh, phase 1 is through cytochrome P450 activity. So phase 1 metabolism, mainly tramadol and fentanyl, and phase 1 through CYP2D6 is codeine and tramadol. So why this is important is drugs which undergo cytochrome P450 metabolism, they have more chances of having drug-drug interaction. So this is very important for us in palliative care because most palliative care patients are having polypharmacy, multiple drugs going on at the same time. Phase 2 metabolism, morphine is a drug which undergoes phase 2 metabolism and no phase 1 metabolism. So it is very safe for patients on polypharmacy. Tramadol is a drug which undergoes both phase 1 and phase 2 metabolism. and also renal excretion is dependent on renal function. So paradoxically, tramadol is the most commonly used drug in palliative care. By palliative care physicians, pain physicians, general practitioner, even oncologists prescribe tramadol routinely. So it's not such a safe drug, if I may say. Now, this was about the pharmacokinetic interactions, but pharmacodynamic interactions, that is, what the drug does to the body, that is, if morphine causes sedation, drug-drug interactions based on pharmacodynamic effects, like additive interactions with other sedative agents like benzodiazepines or antihistaminics, or antagonistic interactions with naloxone, naltrexone. These are seen and you cannot do anything about it. Important thing is about codeine. Codeine metabolizes to morphine and only then does it exert its analgesic effect. For morphine, we have to remember that it has two main active metabolites, morphine 6-glucuronide and morphine 3-glucuronide. So M6G is what has potent analgesic activity, whereas M3G has neuroexcitatory effect and is responsible for the side effects. Hydromorphone we won't talk about. Fentanyl has no metabolites. Tramadol has a metabolite called M1, which is more potent than tramadol. So this was the, in a nutshell, what is important to us with respect to opioid metabolism. Now we will talk about opioids in renal and hepatic impairment, because such patients we often see in palliative care. So the principles are same for opioids also, which are true for all other drugs with, in renal and hepatic impairment. Always start at lower than usual doses. So now there is no standard cutoff that you should give 30% of the dose or 60% of the dose, except of course in renal failure based on creatinine clearance there is. But otherwise there are so many factors which affect opioid metabolism and opioid effect that you have to just you have to tailor make your doses. Secondly, we need to increase the intervals between the doses, and you have to monitor closely for toxicity. So now toxicity of opioids, the symptoms of toxicity are very similar to some of the symptoms that are associated with disease progression. That is why you need to have a high index of suspicion. You need to know your opioid pharmacology properly, as well as you need to know the renal and hepatic values of the patient. Keep on investigating. Investigations are not much preferred in palliative care. But whenever you are giving opioids and the patient has renal and hepatic impairment, we need to know about the renal and liver function, and we need to monitor closely for toxicity, even clinically. So coming to renal impairment. So based on the creatinine clearance for mild, moderate, severe and end-stage renal disease. So codeine is relatively safe. You can start with a normal initial dose and you need to titrate slowly for any sort of renal failure. Morphine is preferably avoided if there is renal failure. However, based on creatinine clearance, if you have to give, for mild renal failure, you have to give 75% of the normal dose. For moderate, you can give 50%. For severe, 25%. Fentanyl is relatively safe. You can give the normal dose or reduce to 50 to 75%. Tramadol, again, you have to decrease the frequency or avoid, because we saw metabolites are active. Buprenorphine or the Vivlor patch that we use, that is totally safe in renal failure. So this was about overall renal failure, but if the patient is on dialysis, morphine is dialysable. So morphine is going to get washed out after dialysis. So there might be rebound pain, or even the patient could go into withdrawal because morphine is entirely removed from the body. Fentanyl is poorly dialysable, and again, it's safe. So if a renal failure patient with severe pain is there, and whether he is on dialysis or not, fentanyl is a good drug to choose for analgesia. Coming to hepatic impairment, morphine we need to use cautiously because we saw that it is metabolized by metabolism, which requires good liver function. You have to increase the dosage interval by 25 to 30% in hepatic impairment. Codeine needs to be avoided. because it won't exert its analgesic activity because it's not going to get converted into morphine, so it won't be effective. Fentanyl is safe, and tramadol we need to avoid in hepatic impairment. So this was about liver and renal failure. Coming to common adverse effects of opioids and their management. So the first common adverse effect is gastric stasis, and it leads to epigastric fullness, flatulence, anorexia, hiccups, and persistent nausea. So this is a very common side effect occurring in about 60 to 70% of patients. Metoclopramide 10 to 20 milligrams 6 hourly can be given to manage gastric stasis. If nausea persists even after metoclopramide, it could be a central cause, and we can give haloperidol. Sedation is a regular effect expected because of mu opioid agonism. And if it's intolerable and it's persistent, usually tolerance develops to the sedative effect of morphine in about 2 to 3 days. However, if there's no tolerance developing, or if the patient is not arousable, you need to reduce the dose of morphine, and it has to be balanced with the analgesia. Cognitive failure is quite rare. Usually it occurs in patients who are already delirious and are started on opioids. Patient may have agitated delirium with hallucinations. Haloperidol 1 to 3 milligrams stat and SOS can be given. Myoclonus is multifocal twitching or jerking of limbs. Drug of choice is benzodiazepine. Might have to reduce the dose of morphine if it's intractable. Constipation occurs due to reduced intestinal motility as well as drying of secretions. So constipation occurs in 100% of patients receiving morphine. So we have to routinely, empirically prescribe laxative along with morphine. Usually a mixed action laxative is prescribed, like Primafin Plus, because of the mixed mechanism of constipation. Pruritus occurs in the form of whole body itching, especially with systemic morphine, more common with intrathecal morphine. And especially if intrathecal is there, localized to the upper body or face or nose. And the drug of choice for this is ondansetron 8 milligrams IV stat and orally BD for 3 to 5 days. So these were about the common adverse effects and how we have to manage them. Now some special cases which we often encounter in palliative care. So opioid-induced hyperalgesia. So this is a rapidly developing tolerance to opioids. And what we see is patient might benefit with the opioid, but the effect is short-lived and pain worsens in spite of increasing the dose. And even the pain pattern may change. Like initially the pain which was localized becomes more diffuse, or it extends beyond the distribution of the pre-existing pain. So this is not limited to very high doses or to any specific opioid. And it is often underdiagnosed. It is very common, and it's more common than we often, than we think that it could be. So only thing is, especially in palliative care, because there is no specific test to diagnose it. It is generally diagnosed on the basis of a high level of clinical suspicion, probability, and recognizing the pattern. And we have to differentiate it from increased pain due to disease progression or increased pain due to opioid tolerance, because the management of both these cases is totally different. So management of opioid-induced hyperalgesia is you have to use a multimodal approach. Like you need to give other analgesics, adjuvants. We have to progressively and rapidly reduce the dose of the causative opioid, and the dose has to come down to about 25% of the peak dose. We have to switch to an opioid with a lesser risk of opioid-induced hyperalgesia. So highest risk is with pure mu agonists, that is fentanyl and morphine, then methadone, and buprenorphine has the lowest risk. And if it's intractable, we can start with oral or parenteral ketamine. So ketamine is often said as the drug of choice for opioid-induced hyperalgesia management. Now we will talk about opioid rotation or switch. So a lot of times we might need to change the opioid if there is circumstances where it's required is poor adherence, or if there is poor response to the opioid with a non-opioid with adjuvant, sometimes patients have intolerable side effect to one of the opioids. So we might have to switch the opioid. There might be sudden changes in patient's renal or hepatic function. There might be opioid-induced hyperalgesia, or there might be neurotoxicity or delirium. So the procedure is to calculate the equivalent dose of the opioid you're planning to switch to, reduce the dose by 25 to 50% of the equivalent dose. I will show you the chart of equivalent dosages. And in circumstances like if already patient is receiving a very high dose, elderly patient, or a reason for opioid switch is opioid-induced hyperalgesia, delirium, or other neurotoxicity. In those cases, we need to reduce the dose. So potency ratio. So now we consider morphine as the gold standard. So morphine, it is considered as 1. So all analgesic potencies are compared with morphine. Codeine is 1/10 as potent as morphine. Tramadol and tapentadol are also 1/10 as potent as morphine. Fentanyl is 100 to 150 times as potent as morphine. So it is more potent. And surprisingly, buprenorphine, although it's a partial agonist, it is almost 100 times more potent than morphine. So this especially I want to highlight because buprenorphine being a partial agonist, it is available freely, does not have the compliances for prescription like morphine or fentanyl have, the triplicate prescription, etc. And even those who are not trained in opioids can prescribe it. But buprenorphine is not such a simple drug, and it should be prescribed cautiously. Now, individual analgesics, I'll just rush through. So tramadol is a centrally acting synthetic analgesic, and it has both non-opioid and opioid properties. So tramadol is often said to be a broad spectrum analgesic because it has opioid properties, non-opioid properties, it acts on NMDA receptors, it acts on serotonin receptors. So it's said to be a broad spectrum analgesic. It is one of the opioids which significantly improves the neuropathic pain, and with a number needed to treat of 3.8, which is very good for neuropathic pain. It is also as effective as codeine as a cough suppressant, and it causes lesser constipation and respiratory depression than an equianalgesic dose of morphine. Only limiting factor with higher doses, dizziness and vomiting, and dependence liability is also less. So, and also it is not a controlled drug. Again, does not have all the compliances that are there with morphine or fentanyl. So again, it's widely prescribed. So one point important I want to mention here is the analgesic effect of tramadol is reduced by ondansetron, possibly by blocking the action of serotonin at a presynaptic 5-HT3 receptor. So very commonly when a patient is undergoing chemotherapy, all of us must have seen that patients are reducing dexa and tramadol infusion, and MSET is given along with it for nausea vomiting. So a lot of times this antagonizes the analgesic effect of tramadol. So this is one practical point we need to keep in mind. For both oral and IV tramadol, conversion ratio is 1/10. I won't go into the details of pharmacokinetics. We'll start with morphine. So morphine is the most commonly used drug, and it's the gold standard treatment for palliative care practice. The reason being it is very cheap. Also, it has a wide therapeutic index, and oral morphine has we also have sustained release preparations available. So 10, 20, 30, and 60 mg are available. So we'll come to morphine prescription. So whenever we are starting a patient on morphine, there are two schemes. Firstly, which is the most preferred, is ordinary or normal release morphine tablets. You start with a 4-hourly dose, usually 10 milligrams 4-hourly, after 1 or 2 days, and also give SOS doses, which are given in an equal amount. Like if the 10 mg 4-hourly is the dose, 10 mg SOS dose is also given. After about 48 hours, we recalculate the 4-hourly dose based on the total used in the previous 24 hours. If the patient has received 2 extra doses, we will add that to the total daily dose and again give it as 4-hourly doses. And for sustained release morphine, when the 4-hourly dose is stable, only then we will shift to sustained release. And we have to also continue to provide ordinary morphine tablets for SOS use. So these are the two schemes. Preferably, we shift over to sustained release once the dose is settled, because these palliative patients don't prefer taking a lot of medication, especially 4-hourly medication. And managing pain crisis, rapid titration is done with IV morphine. So you can do it either IV, or if an IV line is not available, as is seen in most palliative care patients, then a subacute titration can also be done. Before starting the rapid titration, we always give metoclopramide 10 mg IV, and then we make the dilution of morphine as 1 mg per ml. So we give 1 milligram, wait for 5 minutes after IV administration, give another milligram. So you keep on giving that every 5 minutes until the pain score goes down to less than 4, or if the patient starts getting intolerable side effects. For subacute, we wait for 10 minutes between two dosages. Once we have ascertained the oral dose, we have to tell the patient few instructions when the patient is taking the medication home. We tell them to follow all the instructions that we are telling them. We tell them that these medications are not available in routine medical stores. You have to replenish it from hospitals or the place where you tell them to. If there is excessive sleepiness, irrelevant talking, difficulty in passing urine, or excessive vomiting, you have to contact the hospital. Do not share these drugs with anyone else. Often patients do that, I got relief with this medicine, you also take. So that we have to tell them. Then you have to tell them to keep it strictly away from children. And if for any reason the tablets are not used, they have to be returned to the hospital. So these are all the steps we need to take to prevent abuse of morphine. Then we come to fentanyl patch. So fentanyl patch is used once the patient is stabilized, and if there are intolerable, undesirable effects with morphine, if the patient is in renal failure, and patient preference. So the oral morphine to transdermal fentanyl conversion is as shown in the table. So a rough guide that we follow for practical purposes is the 8-hourly oral dose of morphine. Like say if the patient is on 10 milligram 4-hourly, so 8-hourly dose is 20 milligrams. So that becomes his fentanyl patch strength in micrograms roughly. So 20 milligram equals to around 25 mics of fentanyl. This is just a rough practical calculation because otherwise it will take time to calculate. Lack of a lot of times, just transdermal patches usually take time to act and they don't have drastic effects. That's why a lot of times inappropriate use for short-term or post-operative patients who have not received a strong opioid previously can lead to serious side effects. Also, drug interactions we need to keep in mind. Similarly, buprenorphine patches, these are available. We have to remember that buprenorphine is the partial agonist, and that is why patients who are on long-term morphine or long-term fentanyl, if they are shifted to buprenorphine, they could have antagonism of their analgesia. They could even land up with withdrawal. So we have to be very careful when we are shifting downwards towards buprenorphine. Buprenorphine has a ceiling effect due to partial agonistic action. Morphine, fentanyl, they don't have any maximum dose. But buprenorphine, the maximum effect is maximum dose is 140 mics per day. After that, you cannot increase any further. So buprenorphine patches, they are available in strength of 5, 10, and 20 micrograms, and they are 7-day patches. So few instructions that we need to give patients who are on transdermal patches is we have to tell them that the patch is to be applied on dry, non-hairy, normal skin over a flat surface of the body. You have to explain to them that this acts systemically. Because we have had a patient with oral cavity, and when we had prescribed him a patch, when he came back to us after 7 days, we saw that he had applied the patch on his face. So we have to tell him that how does it act? It acts systemically. Also recommended sites, tell them how it should stick, and avoid applying on inflamed or irradiated skin, especially patients who undergone radiation. So absorption will be erratic. Also tell them that the patch is waterproof, because otherwise patients, they don't have baths for weeks together. Then you have to tell them to not cut the patch or remove and reapply the patch. So patches are expensive. So patients do all sorts of things, like they cut the patch into half, or they get pain only at night. So only night they apply the patch, morning they'll remove it and keep it and apply it again the next night, because to save on the cost. So you have to tell them that all this doesn't work. And efficacy is determined by continuous contact with the skin. And if there are any other queries, you have to be approachable. Also, if they have a high grade fever, then what needs to be done with the patch? All that needs to be explained to the patient. So thank you very much for your kind listening. I've covered the practical aspects. So if there are any questions, I'll be happy to answer. Thank you.
That was a very good presentation, Nivedita. You almost covered everything from pharmacodynamics to kinetics to practical applications, adverse effects, their management. Really a comprehensive coverage of the topic.
Thank you.
Moving on to our next speaker. So our next speaker is Dr. Amit Bhatt. He is a consultant medical oncologist attached to various hospitals in Pune, Jupiter Hospital, Lokmanya Hospital. He is also a consultant pain management at Cipla Palliative Care and Training Center, Pune, and director of Avinash Cancer Clinic. He was General Secretary of SARC Federation of Oncologists from 2020 to 21. Ex-faculty of medical oncology, CMC Vellore, and several academic and non-academic publications. You can start your presentation.
Thank you so much, Dr. Manohar. Let me just share my screen.
Yeah.
Okay. Perfect. Yeah. So thank you very much. Am I audible clearly? Hello?
Yes, you're audible. Screen is visible.
Okay, perfect. So we're going to talk about oncologist perspective. We had two very excellent lectures, and I'm going to talk about what an oncologist feels, what is the expectations, and what is the perspective from pain and palliative care. So my talk will be divided into two parts. First part, I'll be talking about specifically about pain, and second about the palliative care. Now, cancer pain, we know that sheer potential of suffering from cancer can be a horrifying experience, and pain probably is the most frightening symptom. The patients who come to us are even scared that chemotherapy will cause pain, all the treatments, medicines, or everything about cancer, including the cancer, will cause pain. So it's a very horrifying experience for the patient. It is well known that 50 to 70% of people with cancer experience some degree of pain, which obviously intensifies as the disease progresses. And in spite of so many medications that are available, less than half of them get adequate relief of their pain, which negatively impacts their quality of life. So this is a lovely paper which talks about what are the perceived barriers, what are the perceptions of physicians. And they're divided into three parts: staff-related, patient-related, and system. We'll talk about only the doctors and the oncologist. The 4 or 5 most important perspectives of oncologists are: there are inadequate assessment, inadequate experience, insufficient knowledge, reluctance of prescribing opioid, time constraints, and poor communication with the patient. We'll just go through all this in a detail. So let me tell you from oncologist point of view, they might be all your oncologists whom you are talking to or who work in your hospital might be excellent onco physicians, but as far as pain management concerns, they are pretty dumb. Most of the oncologists are not very well versed with the pharmacology and with the details of pain management, what are drugs available. and that is a very common thing. So unfortunately they are too proud to accept that, but that's the fact. Poor assessment of pain management. Hardly pain management when a patient comes to the OPD. The assessment of pain management is probably the last. The only a simple couple of questions where pain is there, where is the pain, and then something just gets prescribed out of sudden. So that is what normally happens. There is a very concern about fear of patient addiction, availability and regulation of all the controlled substances. Oncologists might easily prescribe drugs like NSAIDs or tramadol, which Dr. Nivedita, as Dr. Nivedita said, it's probably a difficult drug to prescribe, and they're very scared about prescribing any opioids. Side effects about analgesics and patients becoming tolerant to analgesics. These are very well known concepts and fears which an oncologist has. And the study also shows that oncologists, the dosing of prescribing of opioids, the mean morphine dose is going down and down. The cancer incidence is up, but the mean morphine dose is going down and down because there's a rational fear in the mind of oncologists about opioids and other treatments. This is another study which shows that oncologists really don't know much in detail about pain management. This is a survey taken by oncologists, and most of the knowledge items that were incorrectly answered were related to opioid administration, pharmacology, dosing, adverse reaction, rotation, toxicity. So a pain management physician is required specifically for management, and we'll come to that in a moment. Among the other perceived barriers was fear of addictions. This is a very rational fear, and it happens in a lot of patients. Personally, we had a patient who was taking opioid morphine for a long time. The patient expired, and still the prescription was going under rotation. And 6 months down the line, I received a phone call from the hospital saying that this morphine prescription, which you have written 6 months ago, is come to us. And then we had to file a report with the police and all. So the patient expired 6 months back, but the relatives were taking morphine. So that is the fear, that is the addiction potential which most of the drugs have. And the most important is, as I said, the oncologists are not aware about the basics of opioids and pain management. This is again, as I said, about the dependency on opioids prescriptions, and this is really a big problem. And this is a rational fear for most of the oncologists. So what can be done about improving pain management? What is the expectation of the oncologist from a pain physician? So leaving aside all the other parts, the opioid availability, opioid affordability, structuring, how to structure a pain and palliative process, the most important that I would feel for an oncologist, which a pain management physician can do for an oncologist, is education. A simple basic concepts of how pain management is done. What are the different pain management, what are the drugs which can be used, what are the other drugs can be used. So this is in crux about what I feel as a oncologist expectation from a pain management physician. So step number 1, the pain plan should be clear. And a pain physician should talk with the oncologist about the pain plan. An oncologist doesn't like a patient who comes to his OPD saying that he's in a lot of pain, and he's too proud to admit to give some drugs. So let the pain physician be part of the OPD, sitting with the oncologist and discussing the pain management plan with the patient. So whenever you have an acute patient with an acute pain or a severe pain or a debilitating pain, make sure you talk to the oncologist and sit with the oncologist so that both of you can talk to the patient in detail about what is the pain plan, how the drugs are to be taken. What Dr. Nivedita said, called calculating doses of morphine. I am not sure. I'm pretty sure most of the oncologists don't do it. So you require a specialist for that. You need to also counsel with the oncologist to the patient about an emergency pain management plan. So the patient comes with an emergency, what is to be done, what are the drugs to be given, where is to be admitted, and an oncologist and a pain management should work hand in hand so that this gets tackled and the patient feels confident that no, I am in better hands. Drug interactions. Now, this is one problem where most of the pain management physicians and oncologists differ on. The patient might be on drugs like cisplatin, which called kidney failure, and giving drugs which are, say, toxic to the kidney, NSAIDs, will compound the problems further. Also, polydrug therapy. So many a times it happens that a pain management will give you 2 or 3 drugs. Now, patient is already on multiple drugs. He's already taking a chemical cocktail for his chemotherapy. He's already on multiple anti-emetic regimens. He's already on multiple anti-anxiety drugs. And then addition of multiple polydrug therapy for pain is another additional burden of pills for the patients. So an oncologist and the pain management physician should work so that what is the minimum that can be done with the minimum amount of drugs, minimum of prescription to give the maximum pain relief. Also, drugs like interactions, like for example, a drug called oxaliplatin, which is used in colon cancer, causes neuropathy. So drugs, choosing a pain management drug which will decrease the chances of neuropathy or give good pain relief for painful neuropathy could be given instead of a drug like tramadol or something which is just a painkiller. So such drugs, so a pain physician should go to the bedside, see what are the drugs, what are the chemotherapy that patient is undergoing, and try to find out the side effects and try to adjust the drug so that we can the patient can have relief and the right drug is chosen. Interventions, as an oncologist myself, I'll be more than happy if the patient undergoes some interventions like blocks or some kind of for example, or patches or something like that instead of oral medications, because there are a lot of oral medications which the patient already has to take. So if there is always a possibility of some kind of intervention, many a times I have seen in practice the drugs, the patient is already on multiple kind of drugs and failure of one or step 1, step 2, step 3, and then an intervention comes in. So my personal take is that if an intervention is done earlier and patient has good relief, say for a nerve block, for a back pain, the unnecessary burden of pills might go down. Incorporating pain assessment protocols. Now, most of the admissions, there is most of the oncology hospitals, there is a pain management protocol which probably the nurses does, but none of the oncologists really go into details about what are the pain, what is the pain score and follow up with the pain score. So instead of focusing on the oncologist, the onco associates, the residents of the oncologist or the onco nurse, there is a specific chemo nurse who prepares all the chemos, or there is a daycare staff. So if we can train the daycare staff for some specific pain assessment protocols where the patient comes in and the pain assessment is done, that would be a perfect way of managing the pain from day one of the treatment. So that's all about pain management. Now I'll shift on to palliative care. This is another big issue. Palliative care has been there with us for a long time. Early palliative care referral, Bhatnagar madam has spoke about that early integration of palliative care. Now it is proven that it leads to better quality of life, improved mood, longer survival as compared to standard oncological care. Most of the big organizations, including ASCO, endorse early palliative care for all patients with advanced cancers. Advanced cancers means stage 4 cancer. But despite all these strong evidence and endorsements, less than 40% with incurable cancers have early engagement of palliative care. Now, the reason for what are the problem issues? One of the most important reasons of this low utilization rate is probably that perception that palliative care equates with end of life care. Palliative means end of life and it terminal. So there is a resistance for early integration. So the concept many of the oncologists feel that we don't want to take away the hope from the patient. That patient needs to have some hope to go ahead with the treatment. And if you talk about end of life on day one, then things might go haywire, things might go wrong, and it might create a negative impact rather than a positive one. Many of them have called for rebranding of the term palliative care. Most of the newer oncological guidelines now substitute palliative care with best supportive care. So BSC is a very common term which has been used for palliative care. So instead of palliative care, they divide into BSC, best supportive care, which is throughout the treatment, and EOLC, end of life care, which is at the when the prognosis is less than 6 months. So that is how rebranding is done. So it's important for the palliative care physician to talk to the oncologist how they can help in palliative care. And I'll be sharing you some quotes. So we usually, what does an oncologist do? We usually start talking about palliative care from the second or the third visit. And I start discussing this is not me, this is the paper which is published talking about medical oncology perceptions. And I've just picked up their quotes. I don't want to be it to be a surprise. And when there's chemotherapy, so what they do is after a few lines of chemotherapy, then they talk about it. And it's not really initial when the first day of visit. Perceptions again, medical oncologists, if you ask medical oncologists, everyone knows that this is to be done, but still it's not done. It's like smoking. So everyone knows on the smoking pack, it's written that smoking can cause cancer, and there are very ugly pictures on the tobacco packs and the cigarette packs, but everyone smokes. So it's similar kind of thing. So everyone knows that it should be done, but no one does it. And the real challenge is where how we are going to do it earlier. Well-known oncologist said that unless they become symptomatic, I don't include palliative care in my practice. These are real facts. You need to understand that palliative care referral usually, as of today, is a sequential event following completion of all the potential regimes of systemic and cancer-directed therapy. So when everything that has to be done is done, then the palliative care referral is done and they are taken in at the fag end of the disease. And it's not an integral parallel process, which should as it should actually be. So many a times an oncologist feels if I'm ready to convey that there is either a clinical trial or a second or a third line agent or some kind of drug which the patient can get, then there's some hope. And then at that time telling that they're into take palliative care or hospice, it sends mixed messages. And as I said, the oncologist feels that it really hurts everyone. Third one, medical oncologists express that palliative care physicians are inadequately trained in clinical aspects of oncology, which is very true. So obviously, when the details of oncology drugs available and all the various things. Now, it's not like stage 4 is now patients are going to die in say 2 months or 6 months or 10 months. Now we have stage 4, say lung cancer. When we are doing our oncology, we used to just read about 1 year survivals. And we are now talking about 6 and 7 and 10 years survival in stage 4 disease with all the targeted and immunotherapy drugs. We have immunotherapy drugs which have given complete response in stage 4 disease as well. So oncology obviously is changing leaps and bounds, and a palliative care physician needs to change that a stage 4 doesn't mean that hospice comes on day 1. So a palliative care has to be there as an integral part, but the discussion should be different depending on which position the patient is on. So medical oncologists raised concerns that they were not intimately involved in end-of-life conversations, prognosis, and treatment options. The best way is the palliative care physician, the pain physician, and the medical oncologist sitting together themselves like a tumor board, discussing what they can do for a patient and then together counseling the patient. So the first discussion should be happened on closed doors, not in front of the patient, so that the palliative care physician can understand what the oncologist has in store for the physician, and the oncologist can understand what the palliative care can bring to the table. So this is a very important discussion that should happen. This is a very well collusion which happens within palliative care and oncologists. Often, while our palliative care folks are really good, they know not first to have those conversations without talking to us first. This is what an oncologist has quoted in that paper. Because it takes only a few times for having a doctor to well, why did you say that this to my patient when we have 5 more months of treatment, we have 2 more years to go. So many times there is something or the other treatment, and I said there are very good treatments coming up. So talking about end of life care or a stage 4 disease, or that fact that patient is there is an end point which is going to come on day 1, that might be not a good way to start, and that gives a negative connotation to the entire picture. But talking about every day of how quality every day can be done, how to give a good life every day instead of putting it in some kind of period. So that is more important, which a oncologist feels. Mostly the oncologist, this is like typical driving a bus. The oncologist always has that feeling of being the driver of the entire thing. Medical oncologists view the typical long-term relation and rapport between themselves, the patients, as conferring a responsibility or a duty to guide discussion and decisions about end-of-life care. So the medical oncologist, and we have faced all this. We work closely with palliative care physicians, and we are trying to talk to oncologists. But this is one barrier which always face, that medical oncologists have that perception that they are the captain of the entire ship, and they have to be the ones who have to make the decisions. This is a big barrier. Medical oncologists describe that knowledge of experimental trials, clinical trials, second line, third therapies, all these discussing end of life care. So if all these things are available, so discussing end of life care is again maybe not the right thing to do for a patient who has some kind of treatments there. Maybe a patient might not also like. So end of life care should be at end of life care when we talk about prognosis less than 6 months. But palliative care, good pain management, counseling, supportive care, all these things, the burnout of the patient's relatives, all these to be the care we can take before during the treatment. So goals of care should be discussed with the oncologist. This is again a quote which is there. A person who has rapport or relationship who holds position of authority without regards to the patient or not may be eligible. So the oncologist feels that he has the authority to understand if the patient can continue treatment or not. And talking about hospice without going into talking to the oncologist, most of the oncologists won't be really happy. So coming on to the last two slides, so this is what is happening. So driving the bus, where the first picture, medical oncologist as the authority versus all hands on deck approach, which is a patient center method. This is what we are doing right now. Medical oncologist at the center, and this rapidly has to change, and this can be changed only by education of the medical oncologist and a close interaction between the pain physician, the palliative care physician, as what each of them can bring to the table. What is happening today? A medical oncologist is the main gatekeeper. A palliative care cannot directly talk to the patient. A palliative care will tell his game plan, his reports, everything to the medical oncologist. And then medical oncologist will filter and decide what is necessary. So this is not the right way to go in. We need the all hands on deck approach, where it is a patient centered model. So what we need today, and this is my last slide. So a patient makes a decision. The patient has good knowledge about what is palliative care. As I said, it needs to be rebranding. It can't be end of life care. A patient needs to understand how at the same time, when the hope is to be kept, how palliative care can help him leading a good life for a few months or few years, till actually the prognosis comes bad. How to palliate symptoms, how to discuss hospice, what the palliative care can bring to the table. A medical oncology should help the palliative care and the pain physician to give a good quality life to the patient by open discussion, open concerns, and open game plans. So this is what is going to be a patient-centric model, where the communication is two ways. All are part of the team, and the captain of the team is the patient, and that is the way we need to go forward between palliative care and medical oncology. That's all from me. This is Madam had shown this. So 6 months palliative care is end of life care. This is the concept, needs to be broken. What palliative care is to be started from the diagnosis. It is not end of life care. It has to come from day one of the diagnosis. Patient and the palliative care should bring to the table with the oncologist and how we can help the patient leading a good quality life till actually we are looking at end of life care. Thank you so much.
Excellent presentation, sir. As you rightly mentioned that everybody should be on the same page, the oncologist, the palliative care physician, so that proper treatment plan is explained to the patients and they also know what to expect at what time. Now I shall take the questions. There's one question in the chat box. Dr. Varshali has asked, as rightly mentioned, there is always a fear of opioid abuse. There is always a fear of a patient getting morphine from two places, as we don't have common registry for these patients. So I feel we should have common registry at least at city or district level, and in this era of internet. Seniors, please opine.
Can I answer this?
Yes, ma'am.
Yes, madam.
So, in AIIMS, there is only one number of patients. Wherever patient is going, there is one unique identification number. And then morphine is getting procured only with that unique identification number. So, and if anywhere, wherever he or she will go, if we will put unique identification number, everything will come on the screen that how much morphine he has already procured. So it is always a good habit to keep one file, one number, and this file should move. This is called exactly the patient-centric model, that everything is summarized in the same file, that whosoever is seen, they will put their notes. So when you will see there's a file, that everything will be available on the same file, and the morphine duplicate prescription or misuse or diversion can be prevented by keeping this. And this AIIMS has created a software. We have created a software particularly for this problem, where everything is computerized and with unique identification number. Wherever we will open we will put the unique identification number. Everything will come on the screen. That how much morphine he has taken, who has prescribed, for how many days he has been already prescription has been given. All these things are available on with the same unique identification.
Madam, that will be restricted for AIIMS only, or it goes all over that should be restricted to the AIIMS, right?
Yeah. This software right now we have created for our patients inside the AIIMS, and because National Cancer Institute Jajjar is also there. So, but I have already requested government to have this kind of system, and we are ready to give for, because this is because it's not that if we will start giving is something very secret or very confidential, we can give, and there is no problem in this. But at least there should be some uniformity all over India, because then only we will prevent diversion and trafficking. If we will have uniformity all over India in prescription, record keeping, dispensing, and storage.
Yeah. So that model should be applicable or distributed, or should be there for each hospital and each district at least.
Yeah. So I'm having a meeting probably in the month of 3rd week of September with all stakeholders. Drug Controller General of India will be there. Director General of Health Services will be there. And we are inviting all drug controllers of the state from various states.
Excellent, madam.
We are going to
very nice initiative.
This option so that they can give this this software to all over country.
Very nice option. And second one, madam, even at larger institute, we do keep the triplicates and morphine, all sorts of rules and regulations. But I have seen these small outlets, the private medical store, they just give off or dispense the morphine without any triplicates, and then how to go about that?
With the NDPS Act Amendment 2014, the hospital, those who are dispensing opioids, they should have an in-house pharmacy. And
that we have. Yeah,
everything should be the record keeping, and it should not be a triplicate form. There is called Form 3E. Form 3E means patient number, age, registration number, why we are giving, how many tablets we are giving, and the signature of doctor and patient both. This is the form which should be given to the patient, and this should go to the pharmacy, and pharmacy should keep this form for 2 years, and that's all. So, we have computerized system. Everything is in the computer. Plus this form, we just give the printout, whatever we have written, and they go to the pharmacist in the hospital. There is a counter, pharmacy counter, and they go there, and pharmacists keep this record. That's all. There is no need to keep a triplicate prescription and all this. Is not right now, but still people are. If we have to buy from the market, I think triplicate prescription people are using still.
Yes. Thanks very much, Sushma. That was very informative. I wanted to ask one question. Like nowadays, telemedicine is coming in a very big way. But unfortunately for pain and palliative, we are unable to do any teleconsultations because of that one article which they have introduced, whereby we cannot prescribe narcotics over teleconsultation. So actually, for all our terminal cancer patients, they cannot bring the patient to the hospital. So telemedication will be helpful to them. So can we do anything to change that particular condition in that telemedicine?
So I cannot change right now, but it is not true. If a patient is already on opioids, I think we can ask them to continue opioids, increase opioids. But if you think that patient is imminently dying, or patient is in terminal stage and he needs morphine, by video consultation, ideally, they have asked that through they have asked through multiple medication that through online. It's not only opioids. I think they have given a list of medications we cannot give through online. But if patient is already on opioids, we can just monitor and change the medication. There is no problem. But the purpose is that we should have a solid supervision. Whenever we are prescribing online, we should be very, very sure that we have seen patients through online.
No, that is okay. I mean, even if we do video, I cannot rightfully send my prescription on online. That is the problem, no?
So online,
we really need to create a lobby for this, because this is irrational. You can't expect a patient with multiple meds
Lobby
to come
is
to the
required.
OPD just for this.
Lobby is required in many aspects in this country, lobbying. So we are trying our best. Let's see.
Yeah. Thank you. Thank you, Dr. Bhatt. It was a very good insight, and I'm very impressed that you came up with this idea that we should have polyconsultations and palliative care should be incorporated much earlier. Yeah, we have been really trying to get that to be a reality. Thank you so much for a wonderful lecture.
Thank you so much, ma'am.
Dr. Amit Bhatt, I would like to ask you one question. Like in your, say, conferences or CMAs by oncology, so how many, like there are inclusions of topics on pain and palliative care? How wide we are going in this case? You have mentioned the topic about education and making more oncologists aware of this. So not only med onco, radiation onco, surgery onco, when there is collaborative conferences on all curative modalities.
Yeah, so mostly in most of the conferences, what we have is just maybe one session about something about palliative care, but not really, because most of the oncologists want to talk about oncology a lot, and there are so much new things coming up. If you look at US FDA, they are approving almost 30 new drugs every month for oncology. That's the number. And it's impossible for an oncologist to keep pace with all these new drugs which are coming. And that's probably the conferences, they don't even cover the entire oncology part. Forget about pain or palliation. But what at Cipla, now we have been, during the COVID times, we have been running a program called Impact, which has been early integration of palliative care specifically for medical personnel, for oncologists, for the staff who are working with the oncologist. And we have trained more than almost 30 countries. We have trained more than 1,000 participants. So we have programs like that, and that is how you should go to the oncologist. Probably in mainstream oncology, it's still going to time to come for a conference to come in mainstream oncology. We had done it. We had the SARC Federation of Oncology 2020 and 21, where Cipla had session. We had Cipla session in AMO conferences where I was the chairperson for that. So many a times we have done it, but coming into mainstream oncology, it really is going to take a big effort. But if every, say, pain physician or a palliative physician can sit with his own oncologist, have a straight face-to-face discussion about how you can contribute at different times, I think that should solve the problem at the local level for sure.
Right. And probably, going to the bigger platforms, like you mentioned, it will be more validating, as Sushma madam said, for integration of early palliative care services.
Absolutely.
So we'll look forward to it soon in near future. Thank you so much for coming here and having this perspective from oncologist point of view. That really helped.
Thank you so much for inviting.
Manas, you can take
Form 3,
there
Form 3, there is a question. So, probably, maybe if you, next time, what I will do, maybe half an hour. In half an hour, I will tell you that what exactly the NDPS Act is, what is the amendment of NDPS Act, what is the responsibility of a doctor, how to store, how to dispense opioids, and all forms. It's not only Form 3 which we should be knowing. There are at least 7 forms which we should be knowing. And I will give you the slides also in all the forms. This Form 3E is it's not created by us. It is created by government in NDPS Act. In this form is clearly saying that patient who has been prescribed morphine, he is offered demographic data, he's suffering from this disease, why we are prescribing and how many tablets we are prescribing. So maybe I can, and Form 3 is available on the website. So when you will go NDPS Act 2014, it will be available. Otherwise, I can sometime, if you get time, I can, because I feel it's my responsibility that everybody should be knowing the correct things which is happening in about opioids. So I will let you know. I will tell you everything.
Thank you, ma'am. Yeah, we would like to hear that on NDPA Act and the responsibilities and everything. Definitely, we can have a session on that.
Okay.
I think SSP will be more than happy to have that.
Point
Okay.
noted.
So as there are no more questions, I would like to conclude the session. I would like
Thank you very
to
much.
thank all our speakers to take time out from their busy schedule, and it was really a academic feast for all of us, and a lot of insights and a lot of thinking to be done. Hand over to Varsha for a vote of thanks.
Okay, thank you, Manas. As you have said, the wholehearted thanks to our speakers for such a wonderful insight on so-called, complicated topics. It is not at all. Only the thing is, it should be incorporated and paid attention duly, along with all other modalities in pain and palliative care. And I would like to thank our audience for being here, participating actively, all SSPP members and non-SSPP members as well. Cipla Palliative Care Institute, who has given us this online platform. I would really like to thank them for being here on time and providing, no any technical breakdowns and flawless support. And Anaesthesia TV, who has taken this discussion across the globe on 5 platforms altogether. So they have been our great support, taking this program almost to 800 to 1,000 people at a time. So I would like to thank them as well. And I would like to conclude this meeting. Thank you, everyone, and good night. Thank you.
Excellent. Just excellent.
Thank you. Good night.
Record.